Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Let's do this. All right. Again, back with Dr. David McIntosh, ENT doctor here. And what we did is I asked people on social media, different platforms to throw out some ENT questions. So this is like an Ask the ENT. And I have a bunch of questions here that people would like you to answer regarding all different things. So let's start throwing these out. The first question is regarding venous pooling. So, in the allergy episode that just aired a few days ago, someone asked me, is venous pooling, we talked about it being due to allergies and poor drainage, but could it also be a sign that just someone's tired that has nothing to do with allergies? So,
Yeah,
I mean,
absolutely.
baggy, like dark eyes.
Yeah. Because the mechanism's the same. So we know that in sleep disordered breathing, as a starting point, that you get increased blood flow up into the head, and as a result of that, we don't get the full lymph drainage, so you get a back pressure from there. We
Oh,
know we know that sleep is also a really important part of basically the brain cleaning that goes on at night time. So it's kind of like in the cities when all the street sweepers come out, and then you first thing in the morning you've got these beautiful looking streets, and by the end of the day it looks pretty terrible. And then they tidy it up that night. Well, that same thing happens in the brain. But if you don't do that, then you've basically got this buildup of toxins and all sorts of waste products and those sorts of things in the brain, which then has to find its own way out otherwise. So we've got what's called the glymphatic system, which is the brain's cleaning mechanisms. But then we've got the fact that if you haven't slept properly and you're tired, then basically the brain cleaning mechanism hasn't worked properly, which means that the blood flow system hasn't worked properly, which means we're back to where we started again. So that's how it sort of plays into it as well.
interesting. So when you have sleep disordered breathing, I know there's all that negative pressure in the airway. Is it the negative pressure in the airway that's causing increased blood flow to the head?
No, it seems to be responsive to the fact that the brain wants sugar and oxygen. The brain's quite greedy in terms of its metabolic demands for its weight. It's 10% body weight, 20% blood flow. The most metabolically active part of the entire body is actually in the eye itself. So the brain prioritizes itself from that point of view. So we get this increased blood flow. The other thing, though, that it has, we have this thing called beauty sleep, and it's actually a real thing because if you go without good quality sleep for a few days, things called your collagen and your elastin, which is there's $1 billion industries built around those two words. In your skin, that they start to deteriorate in their quality. So you start to get the swelling, the puffiness, those things called wrinkles start to creep in, and so forth. And that's all part of it. Beauty sleep actually is a real thing.
Yeah, that's interesting. So sometimes when we see people with like really dark, baggy eyes, we can think maybe there's allergies or maybe there's poor sleep quality, like sleep disorder breathing. A lot of blood flow is going to the head and it can't escape as well.
Yep.
Interesting. Okay. Second question is, do you recommend before using a nasal steroid spray such as Flonase to first use a nasal irrigant like Xclear or Neomed to clean the nose out before you apply Flonase?
Yeah. Look, in adults, sure. In kids, you got to choose your battles. Because it's just a reality. So if the child is only going to cooperate to a certain degree, well, the one you want them to cooperate with is the medicated one.
Okay.
So if the child's on board and you can put those extra layers of the cake in for sure, but you want the one that's going to work, medicated wise in as a priority. And this is ideals and reality. And
Yep.
you're working with kids, you got to work with reality. You can forget about ideals because they're going to run their own race here.
Always a good reminder about that too, because we all kind of know what's ideal. And then when you go to implement it, especially when you're like, man, my own kids are the hardest. Well, it's because we're probably voicing ideals to our patients and their families, but our own kids is like, reality doesn't work
Yeah,
so easily.
yeah,
Or at least if we can get the child to blow their nose, maybe before
yeah.
putting the Flonase, that could maybe be helpful. Now, is there a certain time of the day that's better to use a nasal steroid spray? Like before bed?
As a general rule, before they go to bed. Yeah,
Okay.
yeah, yeah.
And if someone has itchy eyes or throat, does that make you think they should also be using a systemic like Claritin or Zyrtec, or does a nasal steroid spray trigger the throat and the eyes also?
A good number of times the nasal spray will address those things as well,
Okay.
but a good number of times is not all of the time. So you want to try and treat, the disease with as much localized therapy as you can. And
Okay.
then if you need to go to systemic therapies as a backup plan, well, look, it's good to have choices.
Okay. And how now I'm thinking this question based off of this. How do you know if the patient should do the Flonase or the whatever nasal steroid spray that they're using in the night and the morning, or just one time during the day?
Well, look, because it's a steroid, I like to limit the medication in children to just a once daily dose. And it's important to realize that these medications are not what we call disease altering. They don't change the disease, they just control the symptoms of the disease. So the disease is still there the next day waiting to happen. The general causes of this are things such I'm working in the context of allergies about breathing and sleep. So, the most common trigger for these problems is dust mite. So, they're going to get exposed to it mostly at night. So, if we've preloaded them beforehand, then they've kind of got some preventative protective therapy on board to try and limit the impact of the dust mite on them. And that's why I sort of target that time of day. If
Okay.
their breathing and sleep is okay, and it's more of it's a grass allergy, and they get really sneezy during the day, but their breathing's not impacted. And this is the important thing is when I look at these things, I break it up into two parts. There's the breathing and there's the everything else. Now, the everything else is the allergy doctor's problem. The breathing problem's mine. So if it's a grass allergy, which is going to be a daytime exposure, and they have no airway problems as a consequence of their allergies, then give it to them in the morning. Give them, again, before their exposure. But I cannot emphasize enough that if there's a sign of allergies, get allergy tested. And if something is found, ask about the targeted allergy therapies. The whole point of doing a test to find a problem is to fix a problem. It's just mind-boggling because they'll get the allergy testing done and they'll be told, oh yeah, you got dust allergy, oh yeah, you got grass allergy, and nothing's done about it. It's like, well, why did you even bother looking if you had no next step to follow through with as to addressing what you found? There's no point in looking.
And in
So
the allergy episode that we did, we talked about immunotherapy. Can they
yeah,
do immunotherapy for a variety of different things at once, like grass and
yeah.
dust?
Yeah,
Okay.
yeah. There's immunotherapy for a whole range of things. It works best for dust mite and grass. So if you're unlucky to have allergies, then at least hopefully have the good amongst the bad that it might be grass or dust mite.
Okay. And then for a patient who gets bloody noses, at times is a nasal steroid spray not a good thing to use?
Nasal spray will make that worse. Correct.
Okay.
Yeah.
So do you recommend not using it, or are there like a
Yeah,
moisturizer
no,
or something
if
different?
you've got a nasal, you've got problems with blood nose and nasal allergies. You've got a few things going on at once that makes it tricky. You've got to get on top of the blood noses. For whatever reason it's causing it, that needs to be sorted and addressed. And
Mhm.
then once that's calmed down, then you can start doing the nasal sprays. Emphasizing technique and just being mindful of wherever the bleeding spots are to make sure you keep the spray away from those points.
And is there a special technique? I remember one of the pediatric ENTs I used to work with said about applying the nasal spray. It's not the way it describes in the
Yeah.
instructions. That's the best way. Can you
Yeah.
describe the best way?
Yeah. So it's an understanding of what's going on inside the nose, and it's deceptive because when we look on the outside of the nose and we sort of see it going up and down in its length, and the holes are at the bottom, so the mindset is the nose itself must go up and down. whereas in reality, it goes backwards and sideways. So the trick with the nasal spray is you put it into the nostril and you angle it towards the outer corner of the eye on the same side of the nostril that you're on, because what we're aiming for is the side wall of the nose, because on the side wall of the nose is that thing called the turbinate, which is the thing that gets dragged into allergies, which is the thing then that swells and blocks and causes the breathing problems. So if you pop it into the nostril and squirt it off to the sides a bit, you're going to hit more of that turbinate and you get more of a benefit from the medication. If you just put it into the nose and spray it straight up, there's not much there that you're going to do anything useful with.
Okay. And then should you, he mentioned propping up the tip of the nose to open
No,
up.
not really. You just got to get the nozzle into the nostril.
Okay.
And if you lift the tip of the nose up, that does make it easier, of course.
Okay.
But that's not essential.
Okay, so there's different ways to apply that. Okay, this is a question from a myofunctional therapist who said, I'm curious what the ENT would say. For a child, I have two patients around the age of 10 and 14 with a deviated septum, where the airflow is almost completely blocked or very restricted, and who are mouth breathers. What I hear is you can't fix the deviated septum until they are older. So would you work on trying to get the lips closed during the day? What about at night? Do you tape at night and only rely on one good working nostril or not tape at all? Can a deviated septum be fixed at an early age, earlier than 10 or 14, I guess?
All right, there's a
We
few
can
things I'm
break
going
that
to
apart.
unpack. I'm going to unpack the big one, big elephant in the room. For God's sake, do not tape these kids' mouths.
Okay.
If this child is mouth breathing and then you go and close the one thing that they're relying on and forcing things through the nose, you're going to cause, and I've seen it, you're going to potentially cause cardiac disease, heart disease, because you're putting pressure on the heart when you do that. Likewise, you're probably going to lead to the nasal valve collapsing, because the cartilage of the nose on the outer walls is under a much higher level of what's called shear stress. And that cartilage is going to fatigue and collapse, and then their nose is going to collapse. And that's where, when you breathe in, the nostrils pinch in on themselves. That's called nasal valve collapse. So the absolute worst thing you can ever do in any child is tape their mouth when they're a mouth breather until their airway's been fixed. You should never tape the child's mouth ever until the airway's been addressed, because 80 to 90% of the time, there is a problem causing obstruction. Mouth breathing is not a diagnosis. It is a symptom, and you got to know what it's a symptom of. And if you don't have the skills and ability to look all the way through, then you are guessing, and that is not healthcare. So that's a big red flag there in terms of my take on taping the mouth just as a starting point.
And this
And then,
therapist says they have a deviated septum and the airflow is
yeah,
blocked. So she knows, or this person
yeah,
knows, there is
yeah.
a
So
physiologic or physical
yeah,
reason, an
yeah,
anatomical reason for the mouth breathing.
yeah. And there's absolutely no reason that they can't be fixed there and then in those children.
Okay. So you can
Yeah.
do a septoplasty at what's
Yep.
the youngest age?
Um, Look, the youngest one I've done was 4 years old. The literature is full of case studies and series where they're doing them in babies. So
Okay.
and they can be incorporated into cleft palate repair surgery, for example, as well. It may be surgeon preference not to do it in children, and that's totally acceptable because that's not what they want to do. But that does not the same thing as saying that it can't be done. It absolutely can't be done. It just may be one of those scenarios where you need to do it out of your district and out of your health fund coverage program, because if the clinician that isn't in your district, isn't in your coverage, then you just got to make a choice. Do you want to have a problem or do you want to have a solution?
And it sounds like
Absolutely
you
can be
don't need to wait until growth is completed of
correct.
the nose and the midface.
Yeah, that paradigm is very well established in the teaching universities of ENT, but clinically and scientifically, there are plenty of people out there doing pediatric septal surgery, and there's plenty of scientific evidence backing up the fact that it can be done.
Okay.
So it's something that we've moved on from, clinically, but it hasn't permeated through academically.
Okay. The next question is, what guides an ENT to perform nasoendoscopy or just an X-ray? And why wouldn't they do any of the above when there are sleep concerns? Some are just visualizing tonsils and not fully assessing airway.
Okay. So what someone is asking me is, why does someone else do what they do? Well, you have to ask that person why they do what they do. I can't speak to that part of it, but I'll speak to the question all the same in terms of trying to be helpful. So I don't do any X-rays in kids. Zero. I don't need to, because what are we doing an X-ray for? To have a look inside. What do I do? Have a look inside. So that is a radiation dose to that child's head, okay, which means their body, their eyes, and their brain. It is a radiation dose they do not need in my hands. So I do not do X-rays at all in kids. I've got the telescopes, I've got the torches, I have a look inside their nose, I have a look inside their throat. Now, that's not to say that having X-rays for other reasons that happens to have a benefit is precluded. So, for example, children going through orthodontic treatments, assessments, and so forth might have X-rays. They're very useful to us, as a sort of as a screening mechanism, and also as a sort of a touch point for the parent to say, look, the dentist found this. Look at these adenoids, or look at this deviated septum, or whatever we trip over. So I'm not averse to children having imaging, but it's not something that I personally need to request as an ENT. So that's the reason that I don't do X-rays. Okay. And then it is totally inadequate clinically to do an ENT assessment if all you're doing is looking inside the throat to look at tonsils,
Hmm.
because you don't know what's going inside the nose. You don't know if the ears are caught up in a disease process, which is not uncommon when there's airway problems. And a good number of sleep disordered breathing, it's got nothing to do with the tonsils. So normal tonsils doesn't mean normal breathing.
And we review that in second episode talking about tonsils and adenoids, and you talked about nasoendoscopy in that episode. So in order to visualize the adenoids from your perspective, you wouldn't do X-ray, but you would just do a nasal endoscopy.
Well, yeah. You obviously work to the comfort of the child. You got to be realistic, and this is not one of those scenarios where holding the child and wrestling them to the ground is going to be successful, because that's counterproductive, and it's mostly not necessary. Mostly we get because they're small, we get a reasonably good view using our little ear torches, where we can actually see through their nasal passages and get an impression of what the adenoids are like. It's not as good as endoscopy, but it's
Oh,
certainly not as invasive as endoscopy either.
you mean an
So,
otoscope?
yeah, an
Like,
otoscope.
and
Yeah,
you look in the nose
yeah,
of a child, you can actually see the adenoids sometimes?
yeah, yeah,
Oh, with an otoscope. Okay, I
yeah,
didn't know that.
yeah, yeah,
Great.
yeah. Well, if you think about it, like looking down through the ear, that's a couple of centimeters. Sorry, we
Yeah.
talk metric here. That's a couple of centimeters, from there to the eardrum. Well, it's just a little extra from the front of the nose to the adenoids.
Wow. Okay. I never really thought that. That's kind of a relief and good information to know. You don't need to do an endoscopy on a child. You can actually see the
Yeah,
adenoids based on
yeah,
that.
yeah.
Okay. Um, so I think that answers that question then. Um, will the next question, I think, I'm not sure if I understand this. Let me know if you understand. Will ENTs acknowledge a home sleep study and recommend treatment based on patient report paired with a home sleep study?
Now, we don't have much in the way of home sleep studies for children. So, if it was in the context of a child question, I don't do sleep studies in children as a rule, full stop, because I don't need to, because the history and the exam give it away. Like the parents go, my child snores and stops breathing at night. Well, I don't need a sleep study to prove that. People have got phones these days; they can record it for me and say, "Look, see, there it is," and I go, "Yep, you're right, there it is." And the sleep studies, again, have the shortcomings. We talked about this in the last episode with the chat study, where the only part of sleep disorder breathing that they were looking at with their sleep studies was obstructive sleep apnea. Um, Jerry Simmons, who's a very prominent and expert sleep doctor, very much is an advocate for the fact that if you're going to do a sleep study in a child, well, you need to do esophageal manometry so you can measure for upper airways resistance syndrome as well. And then you can have the audio so you can listen for snoring, and then you can have the video to look for the mouth breathing, and then we're going to cover the spectrum properly in terms of what's going on. But if you just do the standard sleep study, you're going to come across normal sleep studies where the child's not breathing normally, and it's really an understanding of what we're measuring. So I much more sit on the fence of just simple clinical history and examination findings to be guiding in that regards, because if the child is not sleeping properly, because they're not breathing properly, what else do I need to know? I just need to know why, and again, to get on and fix it. To throw in extra costs and extra delays just to get some numbers on paper that are not going to change what I do. And that's the important thing. It has to change what you're going to do. And if it's not going to change what you're going to do, there's no point doing it.
Right.
It's a pointless and expense, and a pointless time waste if it doesnn't change what you're going to be doing.
Yeah. And I wonder for an adult if that question would be any different.
Right. So
Um,
yes. So in the adult context, so in terms of just going back to sleep studies, so in terms of in lab versus home sleep studies, the in lab is far more accurate because there's a lot more measurements and there's a lot more attention to detail. So, but in the scenario where you're just trying to prove the point, like you're pretty certain this person's going to have sleep apnea, and you just need to get something on paper just to prove it. Look, you don't need to go to that high level testing to get those sophisticated answers if you just need a basic idea, relatively speaking, as to proving the point. So that's where a home sleep study is certainly more than adequate, in terms of doing it. But then there's different levels of home sleep studies, so the ones, so the ones that people like to think would be good is the wearables. So you wear your watch, and it tells you if you've got sleep apnea. Well, it doesn't actually tell you if you've got sleep apnea. What it tells you is whether you fit the pattern of sleep apnea based on a whole lot of data that the algorithm has been fed, and it sort of says, well, it's consistent with, but it's not diagnostic of, so it's in a way, it's a way of being able to check for lots of people cheaply, but it's not the same as being certain.
mhm, mhm. Um, when the next question is, when looking at a lateral ceph X-ray, how do you measure the size of the airway and determine if it's quote unquote large enough? Do you go by millimeters, finger size, eyeball it and guess, or something else? Are there age-based guidelines like how there are for like intermolar palatal widths
Yeah.
for airway
Yep.
size?
Yep. So what I think, because we're talking about a lateral kef, so what we're talking about there really is what's related to the adenoids sitting in the nasopharynx and the space that we take up. And there's two ways of appraising it that are simple enough, that it's applicable enough. One is, and we're not getting calipers out. This is eyeball. We're not going down to the last millimeter here or fraction of an inch, as to these measurements. It's just sort of like what's the sort of impression here, and we're looking from the posterior aspect of the nasopharynx, which you can trace along because you can see the line of the spine. So you can see that lower down and trace that up and around. And then we're looking at the very back of the nose, which you can also see at the lateral kef level. And that's basically from anterior to posterior. So from the back of the nose to the back of the throat. So that's the anterior posterior distance. Okay. So that's what we call the nasopharyngeal aspect of what we're looking at. And then we look at how much of that is consumed by the adenoids. And we create a ratio, and it's called the adenoid to nasopharyngeal ratio, or ANR. Okay. So if you look at the ANR, okay, and it's just big picture stuff, is it half blocked? Is it 3/4 blocked? And there's a rough rule of thumb historically, ENT threshold was 2/3 blocked being a problem. Okay. Scientifically, a 50%, so an ANR of 50% or 0.5, depending on how you want to math it out, same, an ANR of half, okay, is enough to increase the chances of having cardiac disease due to airway obstruction. And this is an important thing to highlight, because we always talk about airway brain, airway brain, airway brain. Well, it affects the cardiovascular system too, including in children. And they can get high blood pressure. They can get the systemic high blood pressure, but they can also get cardiac, or what we call pulmonary high blood pressure as well. And in adenoid issues, it's the pulmonary high blood pressure that can play out. And an ANR of 0.5 is enough, or more, is enough to lead into that. So that's that threshold. But from an orthodontic point of view, in this whole rabbit hole of mouth breathing and orthodontics, an ANR of 0.4 and beyond is correlated with, as the ANR increases, has an increased chance of having associated orthodontic issues as part of that mix as well. So the ENT threshold of 2/3, 0.6 versus 0.5, 0.4, is very different in terms of the health context of what this can all play out for this child. So, but to answer your question, that's how we do that. So that's one method. Okay. Now the second method is looking at the available airway space. Okay. And again, this is a traditional, ENT approach. So what we're looking at here now is from the back of the nose to where we get to the adenoids. So what we're looking at now is not looking at how much space the adenoids are taking up. We're looking at how much airway is left over. Okay. And the space of that airway should be equal to or greater than the thickness of the soft palate that you see on that same lat kef. So if you can see the soft palate hanging down and see how that big that is from front to back, well, the theory is that's what the airway should be. Now, I don't really think that's a great measure, but it's just to explain what's out there.
Okay, so that's interesting. So the person actually sent me a picture of the lateral ceph. I mean, there's nothing identifying factor. I don't have it on
Yeah,
my screen to share. I almost
yeah,
wonder if I could hold it up. Is that okay? Like, there's
of course.
no
Yeah, yeah,
identifying factor.
yeah. And
But
there's nothing here. Usual disclaimers. This is not a clinical diagnosis. This is not medical
no,
advice.
but just
This
out
is
of
a
curiosity.
this is a
This is
random
not a
picture.
medical diagnosis. This is
Yeah,
just
yeah.
opinion. But the person said, the ENT said asymptomatic adenoids and no treatment necessary. But this person said they think there's something related to airway going on for this person. So I don't know if this will show on the screen, but I'll explain it if not. Let's see, related. Okay, let's see. Okay. 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 So what I
It might
see
take
is
this.
incredibly tipped up chin, which I don't think would make this even that valid, but I want you to explain, because now
So,
we've really opened up the airway at its max,
yeah,
and that's not real functioning. The mouth is wide open with low tongue posture. And can you explain here what we see?
yeah. So, yeah, I got a good visual on that, so that's good. Yeah, thank
Okay.
you. Yeah, yeah. So basically, that X-ray fails at the technical level straight up. Okay. So, and that is because of how the child is positioned and postured. Now, look, maybe that child's 2 years old and is not going to cooperate at the best of Sundays, but from a technical point of view, that X-ray is rejected outright. And the reason for that is that to take a lateral kef, the child has to be in what's called it's called the flower sniffing position. So imagine you have a flower and you're going
Okay.
to sniff it. So you're coming to put your head a little bit forwards to have a sniff. That's technically the positioning. What that child is in the resuscitation position. Okay.
Yes.
All right. You will see children when they sleep, they will tip their heads back. So let's go back to some basic first aid here. So apart from in infants, if you in the scenario where you're going to be doing mouth to mouth resuscitation, you tip the head back. Why? Because it opens the airway. What's that child doing in that X-ray? That child is doing first aid on themselves. So to say that they are asymptomatic is just a reflection of the fact that the child is working around the problem. That child is not asymptomatic. That mouth is open. The tongue posture is down. All these things are off track. And looking at that, so let's just reflect on what we said. So let's look at that ANR for a moment, because we can actually turn that picture, because this part of the anatomy doesn't change in terms of, the big picture of where we're at. So you look at the back of the pharyngeal wall to the back of the nose. Those adenoids are taking up a good amount of real estate from what I just saw.
Mm-hmm. And even like the soft palate in this picture, if I show it one more time, the soft palate, like the jaws are back. I mean, it's hard to know because the angle of the picture, but the soft palate is really close to the back of the airway also, right? I can see the soft palate. So perhaps it's not just adenoids, but also jaws that are retruded with the tongue pushing back.
This is that multifactorial element to it. You start with one problem and then you find three more.
But can we not draw really any conclusions because the posture? Like if that child was in that flower sniffing posture, would the airway be smaller?
I am drawing conclusions from that. That child is doing first aid on themselves.
Okay. And even though, do you think the technician put the child in that position?
Mm-mm.
Okay.
No.
Yeah, because I see a little like table or a chin rest or something, and the child's not even touching it. They're upright. They're like tipped up so much. But is it correct to conclude that if that child was in a neutral position or that flower sniffing position, the airway would be even smaller than what we see here?
Correct. Yeah, by tipping the head back, you're pulling it's pulling the adenoids away from the back of the nose. So it's making it
ridiculous that this would be an okay image.
So what we're seeing basically is this is what the airway looks like at its best.
At its best. There you go.
I don't know what it's like at its worst.
No. And you could probably tell by the facial features of, I don't know the child, I don't know anything about it, but I'm assuming looking at the facial features, crowded teeth, narrow palate, low tongue posture, open mouth breathing, that child's struggling. Okay. Asymptomatic adenoids.
Yeah.
Okay.
It'd be a query to sort of clarify what's considered symptomatic to qualify in that context. And I'm not disparaging what's been said or suggested because I don't know this child. I don't know the history. I don't know the full exam. I don't know the ins and outs. So we can talk in generalities, and not, thinking that we're being specific here. But there's definitely enough on the table just from that picture. That's some serious concerns.
Yeah, it's interesting, or is it upsetting for you? Because it is for me to think like an ENT might say situations like that are fine. There's no symptoms, no treatment necessary.
Well, again, we've got to be careful because, again, I don't know what was actually said at the time versus what the parents have said or took away from it.
Right. We know. Okay.
Can be a real big disconnect there because sometimes parents just want everything to be okay. True. And then any glimpse of something sort of being not too bad automatically becomes there's nothing wrong with my child.
That's true. We don't know. Of course, we don't know the story behind this. That's true. I just had a patient referred to my office. The child's now 8.5. Second round of orthodontic treatment because the open bite is relapsing. Child was a mouth breather, never referred for myofunctional therapy. They want a second opinion on the tonsils and adenoids, and the lateral ceph was sent as well to my office with all the orthodontic photos. There is extremely narrow palate at the midline, yet the teeth are very tipped out. So there was some dental expansion, but the skeletal component is not expanded. And the adenoids are occupying the majority of the airway. And it's like, of course, that child's a mouth breather. Of course, you're now on your second round of orthodontics with relapse. Anytime there's an anterior open bite, we need to suspect the tongue is coming forward to escape out of the back of the throat. And it's just like crazy how it takes this much time to realize that that's a problem. And 2 rounds of orthodontics, and the child's entire face is deficient and pushed back. So now what do you do? So anyways, it's just crazy when we can actually see it on the lateral ceph and still aren't sure.
Yeah.
Like, that's showing you where the problem is. Okay. Off that that horse there. So, okay, next question by an OT feeding specialist. She asks, when do they commonly look at tonsillectomy if a child is not progressing with eating? For instance, almost 3, this child they're thinking of, and is stuck on purees and soft mashables after working with a feeding therapist who can rule out sensory and oral motor concerns and looks at
Yep.
function.
Now, what are
Yeah.
we waiting for? I mean,
What?
it should have been on solids at 6 months and building from there. So, and this is where, it's not just an airway, it's a speechway and it's a foodway. And you don't have to have an airway problem. You could just have a foodway problem. And the
Yeah.
problem is that it feeds it becoming a sensory problem, and it feeds it becoming a behavioral thing of adjustment. And just to rewind to our last one, if there is a bit of ASD tendency sprinkled into the mix, oh, there you go. You've basically built yourself into a problem now because you've got a contributing factor that you haven't addressed. So, that aside, the short answer is, you got big tonsils. You're going to have a swallowing problem that is not going to get better because stuff, just doesn't have a clear passage.
Yes.
It's the frustrating thing about this. I mean, this is so basic and comprehensible as a concept, but it's just so hard to permeate through into practice.
Yeah, and hopefully these questions aren't upsetting you as to, like,
Oh,
other,
no,
people aren't, like,
very, very.
other ENTs or people in your specialty area are missing this, right?
Well, look, I don't know what they're seeing,
Right,
and so
we
forth,
don't know what
and
they're
again, yeah, and I sit in a kind of weird part of ENT that for most ENTs would consider quite boring and uninteresting because but I love this space.
Me too, I could listen to you talk about this all day. So, yeah, we don't know what the parents are saying, what they presented to the therapist. I mean, obviously, this is a very educated therapist that has probably
Yeah, yeah.
suggested to the parents.
For the benefit of the therapist, the answer to the question is now. You
Now,
know,
why wait? And for my son, I feel like everything has happened to my kids and my family for some weird reason, but it's helping me like learn so much. When my son was 2 years, 11 months around that time, his tonsils were extremely large. They were graded like 3 plus, almost touching. And it got to a point where he could only eat yogurt and he'd gag and you'd hear him like clearing his throat and stuff. And that
yep,
was just one minor symptom of everything else. But when it got to
yep,
that point, I really was worried. I'm like, he can't swallow. That's what set me off to be like, okay, we have a big problem versus not
yep,
realizing all the other issues were happening. But I
yep.
don't feel like I see that so much in my patients where the large tonsils are causing like a feeding
Yeah,
swallowing issue. To me,
it,
that's less
it,
common.
it's not that common.
Yeah.
But there's probably a selection bias. If it's that bad that they're ending up in a feeding clinic, that those children are selecting themselves out from the crowd,
Yeah.
and there's going to be more apparent as a result.
So OTs, feeding specialists, everybody, let's look beyond sensory, but look also at oral motor, but let's look at not just mechanical and tongue tie, all those components, but
Yeah,
also like medical, like tonsils, adenoids, how is sleep contributing to the feeding issues and
yeah,
things like that. There's so many other components that people not
yeah.
trained in these areas will miss. Okay, next person is a different person. I think this is a dentist. Do you recommend cutting out inflammatory foods such as dairy and gluten in children with nasal congestion or reflux or enlarged tonsils or adenoids prior to a recommendation of surgery? And what is the general protocol if so?
Okay, so here's where we're going to have a disconnect between your country and mine. And I'm not trying to be disparaging, but let's just be honest. I know when I travel to the US, for example, I have major problems with your dairy, major problems with your bread. There is a food quality problem in the United States, and I think you just got to be honest about that. So a lot of the dairy and gluten problems is probably not so much a sensitivity, but a reflection on the food processing and also just an overload. There's just so much stuff that's just processed and put into this stuff, that it doesn't reflect what we experience here in Australia. And again, I'm just being honest. So I know, I can drink milk, eat yogurt to my heart's content here. If I go to the US, I've got to be really, really selective as to which brand of, yogurt I might have, because one, I'm blocked up, I'm congested, I'm phlegmy, and I don't have what I consider to be a dairy sensitivity at all. And it's the same with the bread. I don't even eat the bread anymore because I just can't work out what's what. So from that point of view, I think that's part of actually a much bigger picture problem, that is somewhat unique to the United States on the global scale. And I know that can be a little bit confronting and so forth, but you just got to fly across the border to Vancouver, and it's like you're in a different world with different people.
But
In
and it
terms,
wouldn't be someone from the United States would have that type of sensitivity in Australia or, going
no,
to Vancouver, because it's actually like maybe toxins or more processed stuff you're saying. It's not like we're not used to that type of
yeah, no, it's not
climate.
a custom
Hmm.
to it. It really is something that, I'm not just talking N=1 of me. So I know I can eat bread, whatever. I get nothing until I go to the US, and I don't get it in any other country that I've been to in the world. But that's N=1. So from that point of view, I think, in that context, it's not so much necessarily about, it being dairy or being gluten. It could very well just come down to the quality, and the processing level and so forth, and the challenges that then come with that, because the better quality stuff costs more, and then, and this is why, unfortunately, we have all these processed foods, because they're cheap. And the reason they're cheap is they take all the good stuff out and just leave the rubbish behind. They load it up with the fat and they load it up with the sugar. That's cheap. Protein's expensive. So, they'll take the protein, content down and put the other stuff in to make up for it. So that's part of the problem to answering your question, in the global sense, is because globally, I don't think it's as big a problem as it is in the United States, for the reasons I've hopefully delicately but pragmatically explained.
Hmm.
Having said that, there's no downside to trying that. Okay. And, so that can be a parent initiated thing where they can, what you do is what's called an elimination. So you sort of stop it and let it sort of wash out. So usually for about a month or so. And then you do a challenge. And if you find that stopping it made not much of a difference, and then more to the point, restarting it really didn't make a difference, then that's not that's not your answer. But if you do find, if you want to experiment with that, because that's a home remedy right there. But then you've got to make sure that you're not replacing it with stuff that's also inflammatory and processed, because that's, it's just like you're just swapping one thing out for something else.
Yeah.
So, and again, I think, there's a whole range of other inflammatory foods that you can throw into the mix there. And it's got everything to do with being processed.
Okay.
Yeah.
Not just
And
the dairy
yeah,
component that
yeah,
some
yeah.
people might get
Not just,
congestion from dairy.
that just may be the carrier of
Okay.
you know, it's that's just the net effect of whatever that's gone through, to get
So the
to its state.
inflammatory component is the process part of it, not necessarily as much like the dairy and gluten
Well,
specific.
it can be the gluten load. Like if you've
Okay.
got a lot of gluten, that's overwhelming what your natural tolerance is. Forget about celiac.
Mhm.
You know,
Okay.
Celiac, that you've got a immune reaction issue. But you can have a gluten sensitivity, but that's a dose effect. So if you have a lot of gluten, then you're going to be sensitive to a lot of gluten. It's like the saying, the dose makes the poison. So, and I think that's probably the problem with the processing, is that, you end up with a lot more of certain things in there relative to, what we experience here,
Mhm.
and there is a consequence to that.
Mhm.
And there's a major health crisis in the United States, because of your dietary system. And it is, you're now as a country at the tipping point where you've got, for the first time ever, the next generation has a life expectancy that is less than its previous one.
I've heard of that. Yeah.
Yeah, yeah, that's a worry.
So it sounds like it is worthwhile if somebody is interested in cutting out inflammatory foods before a surgical procedure to see if that might resolve the
Yeah,
nasal congestion or reflux or enlarged tonsils or adenoids. And that's
there,
probably a big process.
there's no downside to it, but but you can pick on those two things, but you really got to do the whole overhaul if you really want to
Yeah.
go in and
Okay.
then slowly introduce things, and you might find that a little bit of it is okay, but a lot of it's not. There's
Okay.
different.
That's a process to figure that out. I'm sure that's
Every,
difficult.
it is.
Next question is, do you feel that all patients should be cleared by an ENT doctor before beginning myofunctional therapy?
Absolutely. Because what you're trying to do is you're trying to rehabilitate function. Now, what has caused the dysfunction is what needs to be clarified, and is that cause still present? So, like we said before, like mouth breathing, for example, classic one. That is not a diagnosis. That is a symptom. Okay, 80 to 90% of the time they are mouth breathing because there is something that is ongoing there at the time. Some of them would have had something in the past that has either been resolved or fixed, and then they need the rehabilitation. But you cannot rehabilitate your way out of a problem that's still there. If the nose is blocked by allergies, you got to deal with that. If they've got big adenoids, you got to deal with that. So from that point of view, from an airway element of myofunctional therapy, absolutely. Now, myofunctional therapy falls into other domains as well. So myofunctional therapy includes the orthodontic aspects, but again, we know that there's a big overlap between having an orthodontic problem and having an ENT problem. So I think there's benefit there. You can have myofunctional therapy in the context of feeding, and again, not as common. But if you've got an airway thing going on, big tonsils, then absolutely. And then from a myofunctional point of view, the other aspect is speech. And again, if you've got ears that are full of fluid and the child can't hear properly, well, their speech is not going to come online in a hurry. If they've got airway problems, they've got a tongue tie, you're not going to be able to rehabilitate them out of trouble. So I really think that it's like we keep saying, teamwork makes the dream work. That why not have an ENT assessment? Again, what is the downside to having things checked? That there's two outcomes. There's either nothing wrong, in which case you got the green light, off you go, or there's a problem that's identified, in which case we've got a problem that we can fix. And that's the best thing to do is find a problem that you can fix rather than not ever find it and then struggle against it forever and a day.
Mm-hmm. And the same person says, what is your recommendation for myofunctional therapists to check for nasal patency? Now, I know we talked about this in a prior episode, checking for like allergies, some signs, but nasal patency, is that in our scope? A lot of us use like the dental mirror looking at airflow that way. So what would you recommend?
Look, you short of looking inside, you're guessing. There's some things that you can definitely spot. If you get them to sniff, if they've got we talked about the nasal valve collapse where the nose pinches in. So if they sniff in and it collapses, well, you can already see they've got a breathing problem for the outer part of the nose. You might be able to get them to tip their head back and lift the tip of their nose up a bit and shine a light in there. And sometimes you can see those nasal turbinates, sort of red little sort of swellings coming across and obstructing the nose. You might see if it's what we call an anterior dislocation of the septum. You might see that it's out of alignment, but that's about as far as you're going to get. All those other things, in terms of assessment and measurements and appraisals, really are sort of just a little bit wishy-washy in the big scheme of things. The other thing you need to be really careful about is there nasal obstruction 24/7, or is it circumstantial? Specifically, is it only nocturnal? Is their nose perfectly fine during the day, but it's not at nighttime because those turbinates are congesting up at nighttime for whatever reason? So you could be careful. We get caught out here in the ENT clinic because we'll look inside the nose and it looks perfectly fine, but we'll go, hang on a sec. Does your nose get blocked at nighttime, but it's okay during the day? And they go, oh yeah. So your nose feels fine now, doesn't it? You go, yeah, my nose is fine now. And they go, yeah, well, that's what it looks like. I'm not going to see your nose at 2 or 3 in the morning, but by the time you wake up in the morning and you're all blocked out, and it takes 1 or 2 hours for that congestion to clear out. Well, any sort of appraisal of the nose when it's good is going to look good. So you got to be mindful that it doesn't, just because it's good then doesn't mean it's good at 2 in the morning.
So, the ENT needs to establish a clear history, or anybody who's looking in the nose to ask about that. The next question, I don't think we're going to answer because it is actually already addressed in the allergies episode, but I want to read it to acknowledge this, that if an ENT screen determines inflammation, which I'm assuming in the nose, is there a protocol to address this initially, or is it a recommendation to look at a surgical approach? Many patients I see don't want an ENT, let's see, because they don't want anything surgical. And what I learned from you, Dr. McIntosh, in the allergies episode is that we want to treat the breathing first and foremost, typically, which might be a nasal steroid
Yep.
to get
Yep.
the patient breathing, and then determine why there's inflammation. If it's due to allergies, the best thing would be to treat the allergies, like cure them with immunotherapy, to resolve that issue. And that's discussed in the allergy episode. So it's not always
Yeah.
straight to a surgical approach.
No, 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 no. And the problem when patients are making these appraisals is that nobody actually knows what's going on until they see one of us. And then it's not like we then lock them in the room and force them to have surgery before they're allowed to leave. They're given options, given choices. you know you know um and then what they choose to do with that information is at their discretion. But if they're making a decision about a treatment they do or do not want before even knowing what their problem is in the first place, then they're missing out.
Yeah.
And I know we're called ENT surgeons, but we're physicians as much as surgeons. We prescribe medications, we advocate allergy shots, and these sorts of things. But if someone doesn't want surgery, that's fine. But at least let them make that decision based on whether that was even what they needed in the first place.
Right.
They're jumping the gun in terms of you know thinking what the outcome is without even knowing what the cause of the problem is.
Right. Thinking, oh, ENT is always going to say surgery, but no, not necessarily. And the person asked another question of what ways are allergies addressed prior to a surgical approach. And I'll refer that person back to that episode, which is all
Yeah, I
about allergies.
think we had a good.
Also, they say, is there a reason laser treatment is not as readily used by ENTs instead of a surgical based procedures? Laser
Mm,
treatment. So maybe radiofrequency ablation?
yeah,
Or I don't know.
radio frequency is not laser.
I don't know.
Yeah. Well, yeah, look, it depends. So, look, I can give you the history of lasers in ENT. So, lasers, in medicine, but ENT became really popular early 2000s. Not for any scientific reason, really just for wow factor, because it's a laser, so it must be cool, it must be good. And it certainly found its niche in cancers. For head and neck, early stage cancer disease, ablative laser therapies as opposed to surgical excision. The difference between removing someone's voice box, versus getting the laser and blasting away a small lesion. Huge difference there. Okay. But then we started using it for a whole range of other things, and they were obviously a lot more in the way of being crude back then than they are now. But we really weren't getting any clinical benefit out of it. It really was just marketing at the end of the day, because it sounded fancy and it was sort of patient demand driven in terms of, oh, I want the laser. And so, okay, here's the laser. So that's in that context. So ENTs, we do use lasers in a huge range of applications. They found applications in ear disease, and cancers would be by far the big two. And in terms of other applications, so things such as in the nose,
Or
and
maybe
other.
they were thinking tonsils, maybe soft. I
Yeah,
don't
look, yeah, I've done a laser tonsillectomy once, and I'll never do it again. Um,
Okay.
yeah, maybe for cancer work again, maybe a different story, but this was just for benign disease. And we thought that it's horrendous. The scar, anything and everything you want to sort of talk bad about lasers, we've done it. So from that point of view, we sort of don't use those lasers. We've just got better ways of doing it. So the nasal procedures, the better ways of doing it than with a laser. Maybe this is in the context of tongue ties, and why don't ENTs use lasers for tongue
That
ties?
could be. Yeah.
That might be where we're at.
Yeah.
Yeah, look, I mean, part of it is because if we're doing other stuff anyway, then we're just going to do it under a general anesthetic at the time, so the child's fully asleep. Then, just spare them that intervention, of being awake, for starters, and we can get in there quite adequately under a general anesthetic and release that surgically, and so forth. So maybe that's part of the dynamic. I'm just trying to answer, the question. The other thing is that there is no better way to do things. These are all just tools. So if you're really good at doing something in a certain way with a certain thing, then just keep doing it that way,
Yeah.
because that's your thing. There's this whole pointless argument about which tool is best. It's like, well, which with all due respect, but which tool is holding the tool? Because that has an impact,
Right.
as what results you're going to get. It's
Maybe
not
technique versus
it,
tool, right?
it,
The technique of the provider.
yeah, it's not the tool as much as the person that's wielding the tool at the time as well.
In
It's both.
certain Yeah, in certain cases. Okay, that makes sense. We just have a couple more questions. This next person said, "Do you look at tongue tie and jaw size when evaluating pediatric patients for sleep disordered breathing? And what are your thoughts on expansion of the maxilla to increase nasal cavity volume?" So I guess that's two part. Looking at
Yep,
tongue tie and jaw size for sleep disordered
yep,
breathing.
yeah. I do that all the time. That's just standard 101 for me.
For you.
That
Yeah.
yeah, yeah, yeah. That's all part of the dynamic, because it's just not tonsils and adenoids, as we've harped on about. So answer the first part. Yep, no problem. Second
And
part.
that's great for you, but not necessarily all ENTs are going to look at that. So
No, no,
let's
no, no. I can't speak for others. This
yeah.
is a question about me.
Okay.
So yep, and then
Expanding the maxilla to increase nasal cavity volume.
it's not so much that it increases the volume, but it reduces the resistance, and they're not entirely interchangeable terms. And that's all because of how fluid dynamics works. So you can have the same volume, but different resistance, just because of the configuration of the tube. So we know that expansion reduces the resistance without necessarily changing the volume, because it changes the shape. So from that point of view, just to be pedantic in the answer, do I advocate expansion? Absolutely. As all part of the get in there with the early interceptive therapies, and get the ENT bits right, get the jaw structure right, get the myofunction right, get everything right, set yourself up on a platform for success.
And like we said, we want a smooth, clear, open airway because we want laminar airflow. And that
Correct.
resistance of airflow is going to increase collapsibility at middle parts, right?
Yeah.
So that makes sense to look at that um, palatal expansion, nasal volume, not so much as volume, but reducing airflow resistance. I like that. Okay, how does CPAP pressure affect carbon dioxide slash oxygen relationship and oxygen transfer from hemoglobin to cells short term and over years of use?
Okay. The problem with that question is that we're starting at the point of having a disease process. So we have gone from normal to abnormal, and then we're trying to salvage back to normal again. Okay. So by virtue of having CPAP, we're getting better air delivery to the lungs, which means we're getting better oxygen delivery to the lungs, which means we're also, as a corollary, getting better carbon dioxide clearance, without increased respiratory rate. So what happens with carbon dioxide? That's the main thing that drives our breathing. And if your carbon dioxide builds up, you'll breathe more. and until the carbon dioxide equilibrates. And that's all done through the respiratory center in the brainstem. And it's all tied in with pH because of the way that the carbon dioxide dissolves into water and dissociates and all that sort of chemistry stuff. So our breathing is primarily driven by carbon dioxide, okay? And in people with obstructive sleep apnea, they can get carbon dioxide retention through the night because they're obstructed. Even if they breathe more, they're still not able to shift more, okay? Because it's wasted effort because they're blocked, and then they don't breathe, and then it builds up. So what CPAP does is it allows better breathing, which then allows for better gas exchange, better sort of breathing patterns as a result, taking away some of the compensatory elements as a result. Now, one of the tricky things that can happen in people with sleep apnea is that over time, they tend to rely on low oxygen as their breathing mechanism as opposed to carbon dioxide. And it's not that the brain has, done anything different. It's just basically I guess, acclimatized to that carbon dioxide level. And then when we put CPAP onto some people, that can take away some of their drive to breathe because they were relying on higher carbon dioxide levels, relatively speaking, to drive the breathing. So that's where some people can end up with some central apnea episodes because of CPAP, because they don't have that carbon dioxide drive, and we've made the oxygen better. So I think that's part of the answer to your question, but I'm happy for you to read it again just to make sure I'm touching the points that
Yeah,
were asked.
no, I think that is an answer because they ask, how does CPAP pressure affect that carbon dioxide oxygen relationship and the
Uh-huh.
oxygen transferring from the hemoglobin to the cells short term and over years of use?
Okay.
So I guess could long-term use of CPAP impact a person's
Okay.
breathing without the CPAP?
Yeah. So one of the things then I think that they threw into the mix there was the hemoglobin delivering oxygen to the cells. So that's really got not much to do with the CPAP at the level that we were talking about. This is all a different part of physiology, which is about oxygen delivery. And the things that drive oxygen delivery is the local environment. There's a whole range of things. So the local pH, is a big factor as to whether that hemoglobin will let go of the oxygen, as is the level of oxygen there to start with. Those two things are interrelated. So yeah, there's what's called oxygen, or hemoglobin desaturation, which is basically what is it that leads hemoglobin to take up oxygen, and then when will it let it go? And it will let it go when there's low oxygen environment. It will let it go when it's in an acidic environment. But that's cellular physiology. It's not entirely related. It's not divorced from what we're talking about in terms of sleep apnea and CPAP, but it's not really a direct correlate at the same time either.
Okay. And when you talked about the central apneas, I know working with the sleep doctor that patients might develop central apneas if the pressure on the CPAP is too high, and that's a reason they may lower the pressure as well.
Yeah, it's not so much what they're doing is they're kind of letting a little bit of sleep apnea creep in so that they can have a bit of carbon dioxide come up so they can have that respiratory drive.
Oh, interesting. Okay, I never knew that.
You're
Okay.
dropping you're dropping the pressures. It means that you're not controlling the sleep apnea as much, the obstructive sleep apnea as much.
Mhm.
And if their
So
breathing
it's like
mechanism is
blocking the breathing a little bit, allowing carbon dioxide to increase in the blood,
so
which delivers more oxygen.
putting the carbon dioxide up so that they don't have the central apneas. You, you,
Yeah.
you- you're walking a tightrope, where
Mhm.
you can basically get really good control of the obstructive sleep apneas, but then the central ones come into the play because you don't have that carbon dioxide drive that you had otherwise.
And you need to get the carbon dioxide built up a little more in the blood.
Yeah.
I never knew that link. I just knew like, oh, maybe the machine's too high. Okay, good. Last question, very last thing. The Apple AirPods are now going to be able to function as hearing aids. Is that something you've heard in Australia? Because that just came out in the United States. Did you hear
Uh,
this?
no, I haven't, but
It just yesterday, I think, was
yeah,
announced
right.
that there is going to be an app, like a new release with the Apple AirPods, where now they are going to function as FDA approved hearing aids, by
Wow.
amplifying sound, and you actually apparently download the app and it will test your hearing on the app, or you can send in or upload your audiological report and the
Yep.
AirPods will adjust, and then you can also manually adjust, but they'll set to the results of your hearing evaluation and be able to function like hearing aids. Obviously, it says for mild to moderate hearing
Yeah.
loss and not for severe, but that's like
Yeah.
a big thing we all just heard about.
So they must be putting microphones into the AirPods. It's the only way that I can see that work, because it's not going to work if you got your phone in your pocket. Then that microphone's going to be muffled by virtue of being in your pocket, compared to the way hearing aids do work, which is that the microphone is built into the hearing aid itself.
Now I wonder do they already have that in these AirPods, or is this a new AirPod? I thought it's the current AirPods, but it's just it's an upgrade or an update in the
Yeah,
system of the current ones you have. I don't think you have to buy new ones, but that's
yeah.
a very interesting thing. I wonder how audiologists feel about that,
I was
but
going to say,
probably
I think take home message from this one is if you own any shares in anything that's remotely related to a hearing aid company, sell them now.
yeah. But also, this may be able to get more people help with hearing loss than how people seeking help now, because it's more common
Yeah,
to have your AirPods in, it's easier
yep,
access, it's a lot
yep,
cheaper. They said it'll be a lot less expensive than actually
yeah,
real hearing aids.
yeah,
And we know there's a link between hearing loss and cognitive decline and
absolutely.
social decline. So this could help a lot of people. But it's also like is it eye health or whatever on the phone will be able to detect sleep apnea, right? And that will,
Yeah,
um, I think, only like
yeah,
more severe sleep apnea. So we're going to get a maybe influx of referrals for that as well. So there's pluses and
yeah,
minuses to all of
yeah.
this modern technology that we'll have to sort through as the patients discover these things. But again, thank you so much. Those were all the questions so far that people presented. And I think it's really important and interesting information. I know everybody's grateful for all of your expertise. So thank you again.
It's a great pleasure as always.
Appreciate your time. Okay, take care, Dr. McIntosh. Thank
Thank
you.
you. Bye.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.